Good afternoon. Good afternoon, everyone. We're going to go ahead and get started in the next minute. If people can come on in and take a seat, we have one last presentation for today. Great. Well, good afternoon again. My name is Yvette Efabera. I am a doctoral student here at the Harvard T.H. Chan School of Public Health, and I am very excited to introduce our final speaker of this evening. David R. Williams is the Florence and Laura Norman Professor of Public Health at the Harvard T.H. Chan School of Public Health and Professor of African and African American Studies and of Sociology at Harvard University. His prior academic appointments were at Yale University and the University of Michigan. The author of more than 375 scientific papers, his research has enhanced our understanding of the complex ways in which socioeconomic status, race, stress, racism, health behavior, and religious involvement can affect health. He is an elected member of the Institute of Medicine and of the American Academy of Arts and Sciences. He was ranked as one of the top 10 most cited social scientists in the world in 2005 and as one of the world's most influential scientific minds in 2014. Among his many positions, he was also the staff director of the Robert Wood Johnson Foundation, commissioned to build a healthier America, and a scientific advisor to the award-winning PBS film series, Unnatural Causes, Is Inequality Making Us Sick? He holds an MPH from Loma Linda University and a PhD in sociology from the University of Michigan. It is my pleasure to welcome a scholar whose work has informed my own decision to attend this institution 6 years ago. Please welcome to the stage Dr. David R. Williams.
Thank you very much, and thanks to all of you for staying by late in the day when there are other things that you could be doing. And thanks to my chair, Dr. Ichiro Kawachi, for the vision in planning such a wonderful conference that we have had enjoyed and been formed by so far today. So I'm going to jump right into my talk on the topic of race, racism, and health. And what I decided to do was to give you an overview of kind of what's the state of the evidence right now, given some emphasis at the beginning to the international dimension of the challenges. We often think of it only as a U.S. Problem, but I'll jump right into my talk. Is there a technology? Okay, good. Working it. All right, so this is a wonderful segue from socioeconomic status to Nancy Adler, a great leader of the MacArthur SES network. And her talk is a good introduction to my talk on race ethnicity, because when people have historically social and behavioral scientists thought of race ethnicity, they first thought about socioeconomic status. So socioeconomic status, as Nancy indicated, is a central determinant of health. But actually, as a sociologist, I learned that social class, and we typically measure it by socioeconomic status, is a powerful predictor of everything desirable within society. So take the SAT test. We think of it as the scholastic aptitude test. Some are calling it, is it the student affluence test? Because of how powerfully SAT scores vary by income level. Here's this indicator. And this is the SAT math, reading, and writing score. And if you only look at the math and reading score, you see this very powerful straight line relationship between SAT scores and family income. That has enormous implications of what it means and how we should use it and how we should interpret it, but I will leave that for discussion. There are, in fact, very large differences in socioeconomic status by racial ethnic categories in the United States. So if you look at 2010 census data, the percent college educated in the United States by race and ethnicity. You can see that blacks, Hispanics, Pacific Islanders, and American Indians have markedly lower levels than whites. And the Asian category, a category heavily made up of immigrants, 70% of Asians are immigrants who have come to the United States with high levels of human capital, have the highest level of college completion. If you look at median income in the United States, and I've translated the actual dollars into a way that we could quickly understand it, for every dollar of income whites have, Asian households have $1.15. Asian households have more individuals contributing to income on average than other households in the US. So if we looked at a per capita income measure, white households would have the highest. But instructively, you can see that Hispanic households have 70 cents for every dollar of income whites have, and African American households have 59 cents. That 59 cents for every dollar is identical to what it was in 1978. And that's 2013 data from the US Census report. It's a striking illustration of the depth of racial inequality that exists even while people tend to perceive that things have been on an upward trajectory. And as Nancy Adler quite said earlier, that if we look at income, income dramatically understates the racial ethnic differences in wealth. So for every dollar of wealth that whites have, Asian households have 81 cents, black households have only 6 cents, and Latino households have only 7 cents. That's the magnitude of the racial inequalities in wealth in the United States. And again, this is the most recent data from a 2014 report. The US is not unique. Here is data from the UK looking at the percentage of low-income households by ethnicity. And you can see both in a recent period as well as a more distal period. So 2007 to 2009 is the light blue color. And you can see the Bangladeshi, Pakistani, black to black households and Indian households, much higher proportion are in low-income categories. So race and ethnicity across multiple contexts, we see a similar pattern. Here is home ownership in the UK, one marker of wealth by race and ethnicity. And you can see much lower levels of home ownership for black Africans, Bangladeshis, and black Caribbeans than you see for whites. And if we look at overall wealth in the United Kingdom, again, you see very striking differences by ethnicity, with the black African, Bangladeshi, and black Caribbean group have markedly lower levels of wealth than whites do. So across multiple contexts, we see this pattern. And what we see with race being so strongly linked to socioeconomic status, it is also the case that in what I call race-conscious societies around the globe, whether you look at Australia, Brazil, New Zealand, South Africa, the UK, United States, Canada, elsewhere, non-dominant racial groups have worse health than a dominant racial group. So here, for example, is data of indigenous populations, looking at the Maori in New Zealand, Aboriginals in Australia, First Nation on reservations in Canada, and Native Americans in the United States. You can see for men in New Zealand, Canada, and the United States, a 7-year difference in life expectancy for the majority population compared to the indigenous population. And in Australia, the difference is 3 times larger than that. For women, you see a same pattern of a striking difference across societies in the association with race ethnicity predicting how long and in fact how well individuals live. Some other quick examples from other societies. Here is data for England and Wales. Infant mortality. It's hard to get official data by race ethnicity for the UK, but infant mortality is one of those indicators reported that way. And you can see the white category has the lowest, white other, and then there's a white British. The 2 black groups next, and then the Pakistani. Surprisingly, the Bangladeshis have relatively low rates, which I don't fully understand. If you look at New Zealand, this is all-cause mortality over time for more recent years versus more going back to the early 80s for males and for females. Again, you see a constant story of race predicts health with markedly higher levels of overall mortality for the Maori versus the European population in New Zealand. South Africa has infant mortality. In this case, whites are 1, and these are odds ratios you can see following the racial hierarchy of South African society. Whites have the lowest rates, then come Indians, and then come coloreds, and then blacks. So that larger racial hierarchy in society under apartheid is still predicts health in South Africa. In US data, there are 2 patterns that are evident. Racial groups that have had a long history characterized by economic exploitation, social stigmatization, and geographic marginalization have markedly elevated levels of poor health. That's true for blacks or African Americans, that's true for American Indians and Alaska Natives, and it's true for Native Hawaiians and other Pacific Islanders. On the other hand, groups that are heavily made up of immigrants, Asians and Latinos, tend to have initially good health. But the best evidence we have suggests that health tends to worsen over time and across subsequent variation, although there seems to be some variation for particular groups. So here's one example of that pattern. This is really cross-sectional data, but looking at persons of immigrant background by generational status in the United States. The first group here is Black Caribbean immigrants. This is first generation. Second generation means they were born in the US, but their parents were immigrants. And third generation, they were born in the US. Their parents were born in the US, but their grandparents were immigrants. And this is a measure of DSM-4 defined lifetime risk of psychiatric disorder or lifetime prevalence of psychiatric disorder. And you can see this striking increase from the first to the second to the third generation with a prevalence of 55% of DSM-4 defined psychiatric disorders, one of the highest levels of psychiatric disorders we've seen in a subpopulation in the United States. And that's true for third generation Black Caribbean immigrants. But remember, the first generation was much lower than the US average. We haven't followed these individuals over time. This is a cross-sectional sample, but this striking pattern. You see a similar pattern for Latinos. By the second generation, they come to the US where the US average is, but the third generation for both Latinos and Black Caribbeans are worse than, in fact, the US average. For the Asian population, you see an increase from the first to the second generation, not quite a striking increase to the third. What we just saw with psychiatric disorders, this is persons in treatment and not in treatment, is also true. Nancy talked about allostatic load. So here's NHANES data for allostatic load. And these are US-born groups on this side. So just let's focus on the 45 to 60-year-olds. And if we look at Mexican immigrants, 45 to 60 years old, their allostatic load score is similar to that of whites, of US-born whites. But by 21 or more years in the US, their allostatic load score does not differ from that of US-born, is identical to that of US-born Mexicans, which is not statistically different from that of African Americans. So within 20 years, they've moved from a health profile similar to that of whites to a health profile similar to that of African Americans. And that is evident in multiple other data sets. We have a study in Chicago where on virtually everything we have looked at with blacks, whites, and Latinos, if we look at Latinos as a group, they look intermediate between blacks and whites. If we simply break out Latinos by nativity status, were you born in the US or not, on everything we've looked at, US-born Latinos look like African Americans, and foreign-born Latinos look like whites. Whether you look at stress levels, at sleep quality, at health outcomes, it's a very consistent pattern that we find. Which means a really important issue is to understand what interventions, if any, can we implement that might reverse this apparently downward trajectory of immigrants in terms of health with length of stay in the United States. By the way, if you look at readily available national data, infant mortality, data or overall mortality data, immigrants of all racial groups do better than their native-born counterparts. So it's a kind of a strike. White immigrants have better health than whites born in the US. Black immigrants are better than blacks born here. Asian immigrants are better than Asians born here. Latino immigrants do better than Latinos born here. Across the board, there's this healthy immigrant effect, but these are just some quick windows on some evidence of deteriorating health over time. I think if we look at the populations that have been in the United States for a long time, there are some real striking patterns that we don't fully understand. One that researchers are using the term accelerated aging or weathering or premature aging. Dramatic racial differences, not only in the onset of disease, but the severity and progression of disease. The persistence of a residual effect of race even after we've adjusted for socioeconomic status. And really powerful effects of life course when we are able to look at that. So here is the striking persistence of racial ethnic differences in health. We have data on blacks and whites going back to 1950. So here's life expectancy data that has good news and bad news in it. The good news is you could see about an 8-year gap in life expectancy in 1950. And you see the gap currently is much smaller. It's about 4 years. It's about half of what it used to be. At the same time, a 4-year gap in life expectancy is very large. And if we froze the life expectancy of whites and had the life expectancy of African Americans increased by the average rate at which life expectancy has increased in the last 10 years, it will take about 25 years to close this gap in health. So it's a big gap that we still see, even though it's smaller than it used to be. But just to give a couple other quick examples, here's the Cardia study. Incident heart failure before the age of 50 was 20 times more common in blacks than whites. Not twice as high, or 5 times as high, but 20 times as high. It's an example of this dramatic earlier onset of disease. Breast cancer is an intriguing case since white women have higher incidence, new cases of breast cancer. But if we look at what researchers are calling the triple-negative breast cancer, which is a type of breast cancer that is much more aggressive, tends to occur at younger ages, and is much more aggressive. Although white women overall have a high incidence, under age 40, African-American women have high incidence, and African-American women disproportionately have the aggressive type of breast cancer. Here's a study using the California breast cancer SARE data, looking at the incidence of triple-negative, just one subtype, triple-negative, and you see it's not only at the very young ages, but at all ages, African-American women are much more likely to have this very severe, aggressive type of cancer. These are relatively old data from Arlene Geronimus, but they show a striking pattern. She looked here at neonatal mortality, death in the first month of life, among first births in the United States by the age of the mother. And we would expect to find, we think of it as certainly socially desirable, socioeconomically desirable, but we also think of it as biologically optimal for a woman to delay childbearing from her teens to her 20s, and we would expect outcomes to be better among those women who delayed childbearing. If you look very carefully at the data, for whites, this is the neonatal mortality in the teens versus the 20s. Rates go down. For Mexicans, rates go down. But for Puerto Ricans and for African Americans, the rates actually go up. So the lowest risk actually exists among those women who had their births as teenagers. So first, it's an unexpected pattern, but then it's a pattern that is divergent for one racial group versus another. Arlene Geronimus' explanation of this was weathering. And what she's saying, that chronological age not only captures how long you have lived, but if you live in a bad environment, it's capturing how long you've been exposed and how much physiological compromise has existed because of the onslaught of environmental exposures. And there is, in fact, considerable evidence consistent with this biological weathering idea. So here is data from Arlene Geronimus, national data for the US from the NHANES study. And if you look here at the allostatic load, we've talked about this before, here's the allostatic load level of whites aged 55 to 64. African Americans reached that same level of biological dysregulation 10 years earlier. So there's a 10-year gap in biological functioning of the two racial groups in the United States. We talked about telomere as well. A study from Arlene Geronimus found that if you look at black and white women in the SWAN study, black women had shorter telomeres than white women at the same chronological age. And in fact, they estimated that black women had accelerated biological aging about 7.5 years, which is about the same 7-year gap that was in one of the studies that Nancy showed us. I would say early in my career, most researchers believed that racial ethnic disparities in health was simply a function of the racial differences in socioeconomic status, which we've looked at and in fact are quite striking. We now know that life is more complex than that. I'll illustrate that with life expectancy data for the United States. At age 25, you can see there's a 5-year difference in life expectancy between blacks and whites. Here's the power of socioeconomic status by education. Whites with a college degree or more education have 6.4 years longer life expectancy than whites with less than a high school completion, so that's big. In fact, the 6.4-year gap is bigger than the black-white gap by SCS. And here, if you look at within the African-American population, you also see a 5.3-year gap between low and high education. Again, bigger than the overall black-white gap, which says we really need to think of socioeconomic status and race, ethnicity, and their joint effects. But yet, at every level of education, by the way, the same is true for income. I'm showing you the education data in the interest of time. You still see the persistence of a race effect. So whites who have not completed high school still live 3.1 years longer than blacks who have not completed high school, and the gap widens as socioeconomic status increases. Just to give one other example of this, with fairly exquisite controls for social class, it's 2 cohorts, all black physicians graduating from Meharry Medical School and from Johns Hopkins about the same time. So they're all physicians, trained about the same time, practicing in the same society. You would think you've exquisitely adjusted for social class, and there shouldn't be striking health differences between 2 groups. However, 23 to 25 years later, the black physicians have a higher risk of cardiovascular disease, earlier onset of disease, incidence rates of diabetes and hypertension twice as high, higher incidence of coronary artery disease, and markedly higher case fatality. If they get sick, much, much more likely to die. So quite striking differences of something else about race that matters even after we've taken socioeconomic status into account. So I think of race as primarily a social category, and I'm not going to make the case for that, but there's a lot of evidence consistent with that. I just want to show you some data that kind of tells the complex story and goes against what I think Nancy Krieger, my colleague here, has shown has been the knee-jerk explanation from the medical world for more than 100 years, is that racial differences reflect fundamental biological differences between groups. So this is data from Richard Cooper and colleagues. And what they did, the same team looked at the prevalence of hypertension in population of West African origin, African Americans in Maywood, Illinois, just outside Chicago, and looked at West Africans in rural and urban West Africa, and at 3 sites in the Caribbean, persons of West African origin. And what they found was this graded relationship as you move from rural to urban Africa to the Caribbean to the United States. If I had, with African Americans in the US having twice the rate of hypertension as blacks in Africa, or if I had inserted what the levels of hypertension were for whites in the US, you would find that whites in the United States have higher rates of hypertension than blacks in Africa. So a simple West African gene hypothesis is not quite consistent with that profile. Here is even a broader set of data that Richard Cooper put together in another paper, looking at age and gender-adjusted hypertension rates for 3 black groups, blacks in Nigeria, Jamaica, and the US. You could see the data for whites, and then looking at multiple European societies, finding that although in the US we focus on the black-white difference and wondered what the genetic reason why blacks have high rates of hypertension, if you put it into a broader European context, you see African Americans have higher rates than in some European societies, but lower rates than in others. So it makes it from predominantly white societies. It makes it much more intriguing in terms of trying to understand these simple explanations. Here is another example. The Pima Indians in the United States have one of the highest rates of diabetes that has been observed in the world. But their cousins, genetically similar to them, living a few miles away in Mexico, the Mexican Pima, have strikingly low rates of diabetes. Again, our government has invested enormous resources trying to understand what is it genetic about the Pima Indians. And if you've watched the Unnatural Causes series, it's a wonderful series, episode that illustrates how the conditions of life that the groups have faced have led to the particular profile of disease that they have. So how do we make sense of these racial differences? I think it's important to recognize that our racial categories reflect simultaneous unmeasured confounding due to ancestral history and geographic origins, as well as environmental exposures. And we really need to think of both the current social environment as well as exposures that individuals have had over the life course and biological adaptation to these environmental exposures, including gene expression changes that have occurred. Why does race still matter so much, even after we've taken socioeconomic status into account? I think there are 4 factors contributing, and there's some evidence in support of each of them. One is health is affected not only by current socioeconomic status, but by socioeconomic status over the life course, and we really have to take a life course perspective. So if we go back to the African-American physicians who graduated from Meharry and the white physicians who graduated from Johns Hopkins, the African-American physicians more likely have been born poor, born low birth weight, grown up poor, experienced deficits in access to medical care and nutrition and so on early in life. So even though their adult socioeconomic status seems similar, their life course exposure was not in fact identical. All of our indicators of socioeconomic status, income, education, occupational status, are non-equivalent across race. National data, we find that compared to whites, blacks, and Hispanics receive less income at the same levels of education, less wealth at equivalent levels of income, have less purchasing power, which is a dramatic example of how life is not fair because African Americans and Latinos are much more likely to live in very bad, undesirable environments, but the cost of goods and services in those bad places are more than in suburban communities. And then personal experiences of discrimination and institutional racism still matter and also has an added pathogenic effect. And then minorities have high exposures to a broad range of other psychosocial stresses. So I want to talk a little bit about racism and the emerging work on thinking of racism as a risk factor. And there are multiple mechanisms by which racism affects health. I think the most powerful mechanisms are institutional, with segregation as being an example of institutional racism. We could think of the current mass incarceration of African Americans as another example of institutional racism. Discrimination also leads to reduced access to desirable goods and services. I'll give an illustration of medical care in a minute. Internalized racism, the acceptance of the society's negative characterization of a group as true of your group is something that researchers have talked about for 50 years, and there are now measures of internalized racism that also seems to have negative effects on health. All this not has been as well studied as some of the other dimensions. Racism can also lead to exposure to traditional stressors, and then experiences of discrimination may be a neglected psychosocial stressor. I put experience of discrimination last. I'm going to talk about that, but sometimes people equate the impact of racism on health as simply the effects of the subjective experience of discrimination. So there's striking evidence that racism or discrimination persists in our society. Some Great evidence comes from audit studies when you hold everything identical and you vary just the race of the individual. This is a study done by Deva Pager. Took 2 black males and 2 white males, sent them to apply for entry-level position, had one of each peer, said he had served an 18-month prison sentence for cocaine possession, was out on parole, and what she found that whether you were black or white, if you had a criminal record, you were less likely to get a call back for a job. However, a white male with a criminal record was more likely to get a call back for a job than a black male whose record was clean. The resumes were identical. She repeated a study in New York City, found exactly the same thing, with the white felon getting higher callback rates than the African American or Latino with a clean record. Let's talk about, so discrimination exists, is the point that I was making by that. Let's think about some of the dimensions of discrimination we don't think about, some of the institutional mechanisms like residential segregation. It's an example of institutional discrimination. Observers of American society for a long time have argued that segregation is fundamental to understanding racial inequality in the United States. John Sell, a historian at Duke University, wrote a book on the origins of segregation in the US South and South Africa. He entitled the book The Highest Stage of White Supremacy. And he argued that residential segregation by race was one of the single most successful domestic policies of the 20th century, because it's beneath the radar screen but has such pervasive, powerful effects shaping outcomes in many ways. How does segregation affect health? Where you live in the US on average determines the quality of education, determines access to employment opportunities. It determines quality of housing and neighborhood environments. Conditions linked to segregation determines whether it's easy or difficult, whether you have a culture of health or not in your neighborhood. Conditions linked to segregation determines access to high quality medical care. So David Cutler, an economist here at Harvard University, did a study looking at a cohort of national study, young African Americans and whites making it in the labor force. He estimated that if you could isolate and eliminate the impact of segregation, you would completely eliminate in this national sample black-white differences in income, education, and unemployment, and reduce black-white differences in single motherhoods by 2/3. All of that driven by place. So segregation is a driver of social inequality, and we are kidding ourselves if we think we're addressing racial inequality without addressing the fundamental challenge of segregation and the ripple effects that it has across multiple domains of society. We can think, this is from the RWJ Commission to Build a Healthy America, on multiple dimensions, what's a healthy community or an unhealthy community, and bottom line is, in our society, segregated communities are unhealthy communities. Importantly, there's nothing inherently negative of living next to someone of your own race. The problem of segregation is not segregation per se, but it's the clustering of social ills, the co-occurrence, what William Julius Wilson calls the concentration effects that exist with segregation. As Wilson and Sampson, Robert Sampson, based on the analysis of the 171 largest cities in the United States, says there's not even one city where whites live under similar conditions to African Americans, and that the worst urban context in which whites reside is considerably better than the average context of black communities. That's the power of segregation to shape place. Massey also documents that the segregation of African Americans is distinctive. It's distinctive historically. Other groups, immigrant groups, have experienced some degree of segregation, but no immigrant group has ever lived under the levels of segregation that currently characterize the African American population, and that the most affluent, this is the 2000 census, blacks were more segregated than the poorest Latinos and Asians. Although there's dramatic increases in segregation for Latinos, which is something that should concern us. One of the points that the message from segregation and its power tells us is that racial differences in socioeconomic status, the striking differences I showed by income and by wealth, didn't just happen. They're not acts of God, they're not random events. They reflect the successful implementation of social policy. They are distal, upstream social processes that have produced these outcomes that we see. Let me talk about quickly some other mechanisms of racism. Internalized racism has to do with the extent to which some members of a stigmatized population accept as true the society's negative characterization of that group. There's not been a lot of work on internalized racism, but there's some evidence suggests that higher levels of internalized racism among African Americans is linked to poorer health. Jerome Taylor has developed a scale to measure internalized racism, and he's found that 1/3 of African Americans are high on internalized racism. This is based on his studies of multiple community groups and student populations. He's not really used large random studies, but he's done a lot of studies over his career, and he came up with this 1/3 number. He also finds higher levels of internalized racism is linked to both elevated risk of substance abuse and mental health problems. Intriguingly to me, if I look at the work of Ian Pardes from Australia, studying internalized racism using a very different measure with Aboriginals in Australia, he also comes up with 1/3 of Aboriginals have been high on internalized racism. So across two very different contexts, similar estimates exist. But we haven't really explored the health consequences systematically. The work of Jerome Taylor and his colleagues linking it to mental health outcomes and substance abuse, and some of his colleagues like Tull linking it to abdominal obesity in both the African American population in the United States as black populations in Africa and the Caribbean. They find that link as well. Perceive discrimination as one type of stressful experience that has consequences. This is from a recent review where we find that discrimination is linked to a broad range of outcomes. In addition to mental health and other self-reported health outcomes, we find it linked to a much broader range of outcomes. It also is linked to delays in seeking treatment, lower adherence to treatment regimens, and lower rates of follow-up. So it not only is adversely impacting health, but it's affecting how individuals access and utilize the healthcare system. Importantly, most studies of perceived discrimination in health have not examined the role that it plays in accounting for racial disparities in health. However, we do have some studies from the United States, from South Africa, from Australia, and New Zealand that all find that discrimination helps to explain the residual effect of race that remains after we have adjusted for socioeconomic status. So we have empirical evidence that discrimination is a contributor, self-reported discrimination is a contributor to racial differences in health across multiple societies. To illustrate the work on discrimination, I'm going to highlight a scale that I developed called the Everyday Discrimination Scale that was trying to not capture just the big experiences of discrimination, like being not hired for a job or being treated badly in housing or badly by the police, but trying to capture the extent to which discrimination is patterned into the day-to-day experiences of individuals. You're treated with less courtesy than others and treated with less respect, and people act like you're not smart or if they're afraid of you. Just to illustrate the work with this, I'm looking at the work of one researcher, Dr. Tanya Lewis, who was at Yale, now at Emory. And each line on this slide reflects a different study she did, all of them using the same measure, everyday discrimination. In one study, she finds everyday discrimination predicts higher levels of coronary artery calcification. Another one, higher levels of inflammation, higher blood pressure. Study of women who just given birth predicts lower birth weight. A study of the elderly predicts more rapid declines in cognitive impairment over time. Discrimination in a community sample predicts poorer sleep, both objectively and subjectively assessed. Everyday discrimination is actually associated with elevated risk of mortality in a study of the sample of the elderly followed over time. And in a sample of African American and white women, higher levels of everyday discrimination is unrelated to waist-hip ratio, unrelated to subcutaneous fat, but predicts higher levels of visceral fat, exactly the deep fat, abdominal fat within your organs that predicts higher risk of a range of outcomes. So this illustrates the fact that discrimination is really a factor that predicts a broad range of outcomes. In addition to developing the Everyday Discrimination Scale, if you read the qualitative research on experiences of discrimination, it's not only the actual exposure to discrimination that may matter, but just like other psychosocial stressors, the threat of the discrimination may also play a role. So when I developed the Everyday Discrimination Scale, I also developed what I call the Heightened Vigilance Scale. So right after we asked individuals questions about everyday discrimination, we asked people, in thinking about dealing with experiences you just described, how often you think in advance about the kinds of problems you're likely to experience, how often you try to prepare for insults before leaving home, how often you feel you always have to be careful about your appearance to get good service or avoid being harassed, how often you carefully watch what you say and how you say it. You see a level of physiological arousal because of how threatening the environment might be. This is 3 recent studies with colleagues that find high levels of everyday discrimination. A sample in Baltimore with Tom Levis is linked to elevated risk of depression and contributes to the black-white disparity in depression. High levels of discrimination, a sample from Chicago, predicts sleep difficulties independent of income and education. High levels of discrimination also predicts high levels of hypertension, and vigilance is predictive of hypertension over and above everyday discrimination. So it makes an added contribution over and above the actual exposure to discrimination. Another mechanism of discrimination affecting health is discrimination in medical care. The Unequal Treatment Report from the Institute of Medicine in 2003, there's a number of studies that shows what was found now still persists. And what the IOM study found and reported in 2003 was across virtually every therapeutic intervention, blacks and other minorities receive fewer procedures and poorer quality medical care than whites. To illustrate, give you a concrete example, this is just one study. These disparities were best documented in the area of cardiovascular disease, but this is a good example. Dr. Todd was an emergency room physician at UCLA. He asked a simple question. When a patient comes into the UCLA emergency room with a long bone fracture, a broken bone in the arm or leg, does the patient's ethnicity make a difference with whether the patient gets pain medication or not? And when he looked at medical records for a year, he found that 55% of Latino patients with a long bone fracture had received no pain medication compared to 26% of non-Hispanic whites. Dr. Todd was a good researcher, he said, confounding. So statistically, he adjusted for whether the patient was male or female, spoke English or Spanish, whether they got injured on the job or not, what time they showed up at the ER, how long they spent in the ER, the severity of the fracture, thinking of every other possible explanation. When he statistically adjusted for all of these factors, the single biggest predictor of whether the patient got pain medication was whether the patient was Hispanic. Dr. Todd moved from UCLA to Emory University, repeated the same study at 3 emergency rooms in Atlanta, and found exactly the same thing looking at black and white patients. A black person who shows up at an emergency room in Atlanta with a broken bone in the arm or leg is less likely to get pain medication compared to a white patient. And the question is, how on earth do we make sense of that? How do we understand in a society with high-trained medical professionals who go to work every day to do their best for their patients can still produce a pattern of care that appears to be so discriminatory? One of the explanations, for which there wasn't hard evidence then that the IOM committee suggested, was this phenomenon that social psychologists have been studying for a while called implicit or unconscious bias or unthinking bias. It's an automatic process, it's an unconscious process. What it takes for this to activate is the presence of implicit biases. And there's a lot more scientific evidence, and there are now studies that actually directly link implicit bias on the part of the patient to provider, to provider behavior. So we now know this is a factor leading to outcomes. We also have good evidence that these biases are deeply embedded within our culture. The Beagle Project is a project of a huge data set of 10 million words that represents what the average American would read, college-educated American would read over their lifetime. It's like putting American culture into a database. If you do that, the beauty of that, you can now look at associations within the database. So when the word black appears in American culture, what is it most closely associated with? Poor, violent, religious, lazy, cheerful, dangerous. So police officers who assume that a black person is violent, lazy, and dangerous are not bad cops. They are normal Americans. They are simply reflecting what the society has fed them over their lifetime. In contrast, when white occurs in American culture, same database, wealthy, progressive, conventional, stubborn, successful, educated. For the fun of it, female, distant, warm, gentle, passive, male, dominant, leader, logical, strong. But the key point is that if you look at the 10 most common, those with the highest, you can think of this as a measure of associative strength. The larger it is, the stronger the association. It's not really a simple correlation, but you could think of it in those terms. It's similar to that. So you can see that the negative images of blacks in American culture versus whites is very a striking difference. There are studies about what we can do to reduce these biases. I pointed to the work of Diana Burgess and colleagues. I don't have time to talk about it, but they point particularly to the individuation versus social categorization. Categorization is normal for us, and focusing on individuation is important. What can we do about this? I want to spend my last few minutes talking briefly about areas of intervention. I can't talk about them at length, although I have papers that describe these issues at length. One is, I agree with Nancy, there's much more that can be done within the healthcare sector than we think. So here's an example of a study done around colorectal cancer by the state of Delaware, where they provided, the state would provide free to every resident of the state of Delaware, both screening and treatment for every resident. If you didn't have insurance, it was provided for you. They also had a navigator problem to make access feasible for individuals, and they also had special outreach efforts to the African American community. This program, between 2001 and 2009, eliminated disparities in screening for colorectal cancer. It eliminated incidence rates for colorectal cancer in the state of Delaware, and it led to a very near elimination of the mortality difference between blacks and whites in the state of Delaware, documenting that at least for some health conditions, a full court press on the medical front can in fact make a big difference. But we need to do more than that. We also need to think of the ways in which we can deliver care that addresses the social context. Because what do we accomplish if all we do is treat illness and send people back to live in the same conditions that made them sick in the first place? And there are a number of initiatives, some of them born in Boston, like the Medical Legal Partnership, for example, that offers an example of ways in which you can more comprehensively address the social context. But I think the big challenge, and I only have a little time to talk about it, is that we really need to move upstream and think of how do we address the fundamental non-medical determinants of health, including place-based solutions, given the centrality of segregation in creating social ills, which is the challenge of how do we redefine health policy to include policy in multiple domains of society that have health consequences. There is evidence, we talked about moving to opportunity earlier, that neighborhood and housing quality and interventions to improve neighborhood and housing quality can lead to improvements in health. The MTO is one example of that. The Yonkers Housing Intervention is another example of interventions in the housing domain having positive effects on the health of disadvantaged populations. We need to think of what we can do to improve economic well-being. There is work by Peter Arno and Jim House and others showing that Social Security and providing a safety net of financial support through the Social Security system looked at and analyzed over decades actually led to improvements of the health of the elderly in the United States. So providing additional economic support does matter for health. If we look at the impact of civil rights policies, it's quite striking. Because the gains of the civil rights movements that were most evident between the mid-1960s and the mid-1970s, we had a narrowing of the black-white gap in income. Commensurate with the narrowing of the black-white gap in income, we had more rapid improvements in the health of African Americans compared to the health of whites, and a narrowing of the black-white gap in health. That's evident in studies of mortality by Richard Cooper, by George Kaplan, by Ammon and Che, that the civil rights movement had a dramatic effect on health. And what happened after the civil rights movement? Here is the black-white gap in income. So in 1978, blacks earned 59 cents for every dollar whites earned. And you can see throughout the decade of the 1980s, the decade of Reaganomics, the gap widened, went down to as low as 55 cents in 1982, and it wasn't until 1994 that blacks got back up to where they were in 1978, and you notice I saw in 2013 they're back to where they were in 1978. What happened during the decade of the 1980s, you can see for 5 years in a row after 1984 that the African American mortality, 69.5 years in 1984, was lower than it was in 1984, while you see a slight upward trajectory, not dramatic for whites, but you see this decline from the 1984 level for African Americans over time. In other words, we need to think of what's the relevant lag times and that it took for these things to happen, but what we see a global pattern of when the economic gap narrowed, the health gap narrowed. When the economic gap widened, the health gap widened. There's other evidence that I don't have time to talk about that economic policy has dramatic effects on health. Investment in early childhood policies to change the trajectory very early in life. For the Perry Preschool Project, the Abecedarian Project, shows us these strategies that have enormous promise. Let me conclude. Racial inequalities in health are created by larger inequalities in society. Socioeconomic and racial ethnic disparities in health reflect the successful implementation of social policies. Eliminating them will require political will for and a new commitment to new strategies to improve living and working conditions for disadvantaged populations. We need more research that takes the complexity of the social context seriously and tries to find ways in which we can dismantle the system, as Reskin argues in a recent annual review of sociology paper, the system of racism in our society. But I also believe that another great need of ours is to use in a systematic manner all the knowledge that we have. We do have a lot of knowledge now that shows a number of promising strategies to effectively address inequalities, and we certainly need to move in that direction. And as we do this, and as we see the need for race-targeted policies, I want to leave you with the words of Thomas Jefferson: there is nothing so unfair as the equal treatment of unequal people. I've talked about groups in our society defined by race and ethnicity that are dramatically unequal. And we cannot think of equal policies for persons who are different starting points. So there's really nothing so unfair as the equal treatment of unequal people. Thank you.